I'm about to reveal something that might shock you if you're over the age of 70 and your doctor has recommended surgery. I'm Dr. Emma Whitmore, and after more than 2 decades as a cardiovascular and surgical consultant, I've stood in operating rooms where lives were saved and others where the outcome changed a family's life forever. I've reviewed thousands of surgical charts, watched patients wake up from anesthesia confused and frightened, and seen firsthand what happens to the aging body under surgical stress. And I can tell you with absolute certainty that almost everything you've been told about surgery after 70 is incomplete. You've been told that if a scan shows a problem, fixing it surgically is the best option. You've been told that modern medicine makes surgery routine. You've been told that if your doctor recommends it, the benefits must outweigh the risks. Except that's not always true. Because aging changes the body in ways most medical guidelines barely address, and those changes can turn what looks like a routine procedure into a devastating physiological shock. Margaret was 76 years old when I first reviewed her case. She was a retired school librarian, walked 2 miles every morning, and had done exactly what every doctor had advised for years. Her blood pressure averaged 128/72, her cholesterol was controlled with medication, and her cardiologist described her as remarkably healthy for her age. But an MRI showed degenerative changes in her spine. Her doctor recommended spinal fusion surgery to stabilize the joints and reduce chronic pain. The operation lasted nearly 5 hours. The surgery itself went exactly as planned. The hardware was perfectly placed. The scans looked excellent. But within 24 hours, Margaret became disoriented. Her blood pressure dropped when she tried to stand. She couldn't focus. Her daughter described it as if her personality had suddenly disappeared. What happened wasn't a surgical mistake. It was biology. When the body ages, the cardiovascular system, brain circulation, and metabolic reserves become far less resilient under stress. Imagine your body's circulation system like a complex network of irrigation pipes feeding a garden. In your 40s and 50s, those pipes are flexible and responsive. When demand increases, blood flow adjusts instantly. But by the time someone reaches their 70s, those pipes often become stiffer, narrower, and less adaptable. Now introduce anesthesia, blood pressure shifts, inflammation from surgical trauma, and hours of immobility. Suddenly the brain, which requires a constant, precise flow of oxygen, experiences subtle but powerful disruptions. This condition has a name, postoperative delirium, and it affects up to 30% of older surgical patients. Comment below your age and whether you or someone you love has ever had surgery after 70. Because what I'm about to explain next will show you why procedures that appear routine on paper can trigger cascading effects throughout the aging body. And before I reveal the key decision framework that can prevent these tragedies, you need to understand the hidden biological mechanisms most people and many physicians never fully discuss. I'm about to show you the biological mechanism that turns many surgeries after 70 into something far more dangerous than most people realize, and once you understand it, you'll never think about surgical risk the same way again. The problem isn't just the procedure itself. It's the aging body's ability to maintain stable circulation under stress. Let me explain the biology. Imagine your brain's blood supply like a city's water pressure system. In a young body, pressure adjusts instantly when demand changes. Stand up, blood vessels tighten, pressure stabilizes, and the brain continues receiving oxygen without interruption. But with age, that automatic pressure system becomes sluggish. The arteries stiffen. The receptors that sense pressure changes respond more slowly. This condition is called impaired cerebral autoregulation, and it means the brain becomes extremely sensitive to even small changes in blood pressure. Now introduce anesthesia, which naturally lowers blood pressure. Introduce blood loss during surgery. Introduce hours of immobility on an operating table. Suddenly, the brain experiences repeated episodes of reduced oxygen delivery. Not enough to cause a stroke, but enough to disturb brain metabolism. This is when postoperative delirium appears. Patients wake up confused, agitated, sometimes unable to recognize family members. And the numbers are startling. A large analysis published in the Journal of the American Medical Association followed more than 5,000 adults over the age of 70 undergoing major surgery. Nearly 1 in 3 experienced postoperative delirium. But here's what most people don't realize. Those who developed delirium had nearly double the risk of long-term cognitive decline within 3 years. That's not a small difference. That's the difference between living independently and needing full-time care. Thomas was 79 when I first reviewed his case during a hospital consultation. He was a retired construction supervisor, strong hands, still active in his garden every morning. He had been diagnosed with moderate carotid artery narrowing during a routine ultrasound. The scan showed about 60% blockage in one artery supplying blood to the brain. His doctor recommended a procedure called carotid artery stenting to open the vessel and reduce stroke risk. On paper, the logic sounded perfect. Widen the artery, improve blood flow, prevent stroke. But here's the part that rarely gets explained. The brain adapts to gradual narrowing over years by developing alternative pathways for blood circulation. When a stent suddenly restores full pressure, those fragile compensatory vessels can struggle to adjust. Imagine you've been watering a delicate garden through small channels for years. Then suddenly someone opens a fire hydrant into the same system. The pressure surge overwhelms the delicate balance. In Thomas's case, the procedure technically succeeded. The artery opened beautifully, but within hours he developed severe confusion and visual hallucinations. His brain had experienced what we call hyperperfusion syndrome, where restored blood flow temporarily overwhelms the brain's fragile circulation control. The condition resolved eventually, but the cognitive changes lingered for months. Now here's the second mechanism most people never hear about: inflammatory cascade activation. Surgery is controlled trauma. The body reacts by releasing inflammatory molecules called cytokines. In younger adults, this inflammatory response is quickly regulated. But in older adults, immune regulation often becomes exaggerated and prolonged. Imagine a small kitchen fire triggering every fire alarm in the city. That's what happens biologically. Cytokines travel through the bloodstream, cross the blood-brain barrier, and disrupt neurotransmitters responsible for memory, attention, and sleep cycles. Researchers studying postoperative brain function have identified specific inflammatory markers, interleukin-6 and tumor necrosis factor alpha, that spike dramatically after major operations in older adults. A study published in the Journal of Neuroinflammation found patients with the highest inflammatory responses were 40% more likely to develop prolonged cognitive dysfunction after surgery. Comment below if you've ever seen an older family member become confused after hospitalization or surgery. Just type the word confused. Because what I'm about to reveal next may be the most important factor of all, something almost never discussed during surgical consultations: the concept of physiological reserve. Your body has a hidden safety margin, a biological backup system that helps you recover from stress. But after 70, that reserve often shrinks dramatically. And when it disappears, even procedures considered routine can push the body beyond its recovery threshold. In the next section, I'm going to explain how doctors measure this hidden reserve, why many surgical recommendations ignore it completely, and the decision framework that can help older adults avoid procedures that offer far more risk than benefit. When you truly understand surgical risk after 70, the conversation changes completely, because the most important factor is something most scans, lab tests, and even surgical evaluations never measure. It's called physiological reserve. And if you imagine the human body like a battery, physiological reserve is the amount of energy left when the system is under maximum stress. In younger adults, the battery is large. Surgery drains it, but the system recharges quickly. In older adults, the battery is often already half empty before the operation even begins. This is why two patients can undergo the exact same procedure with completely different outcomes. One recovers in weeks. The other never regains their previous level of independence. Harold was 81 when he came into the clinic complaining of severe knee pain. Imaging showed advanced osteoarthritis. The cartilage in his knee joint had worn down significantly, and his orthopedic surgeon recommended total knee replacement. Now on paper, knee replacement can be one of the most successful operations in modern medicine. Studies published in the Journal of Bone and Joint Surgery show more than 80% of patients report improved mobility after the procedure. But statistics don't tell the whole story. Harold had type 2 diabetes, mild heart disease, and reduced muscle strength from years of inactivity. Each of those factors quietly reduces physiological reserve. Imagine trying to rebuild a damaged bridge. If the support beams are strong, the repair holds. But if the foundation is already weakened, adding construction stress can collapse the entire structure. Harold's surgery technically went perfectly. The artificial joint was positioned flawlessly. The postoperative scans looked excellent. But the rehabilitation process required months of intensive physical therapy. His muscles struggled to respond. His blood sugar became unstable from the stress response. 3 weeks later, he developed a blood clot in his leg, a complication known as deep vein thrombosis. The body simply didn't have the reserve capacity to handle the surgical trauma and the recovery demands simultaneously. Now here's the third mechanism that almost no one explains before surgery: the interaction between anesthesia and the aging brain. The brain relies on precise chemical signaling between billions of neurons. Neurotransmitters such as acetylcholine, dopamine, and glutamate regulate memory, attention, and awareness. General anesthesia temporarily disrupts these signaling networks. In younger brains, the networks restart quickly once the medication leaves the system. But in older adults, those networks often take much longer to reset. Imagine shutting down a large airport. In a small-town airport, operations restart quickly. But in a massive international hub with aging infrastructure, restarting the system takes far longer and problems ripple across the entire network. A major study published in Anesthesiology followed more than 1,200 patients over age 70 undergoing major surgery. Researchers measured cognitive function before and after procedures. Within 1 year, nearly 25% experienced measurable long-term decline in memory or executive function, not mild forgetfulness. We're talking about the difference between managing finances independently and needing assistance with daily tasks. Comment below if you've ever heard the phrase, "I'm just not the same since that surgery," because that statement appears in patient histories far more often than people realize. Now I want to be very clear about something. Surgery can absolutely save lives. Emergency procedures, trauma operations, and interventions for life-threatening disease are essential. But when surgery is elective, meaning it's recommended to improve quality of life rather than prevent immediate danger, the decision becomes far more complex. This is where the concept of benefit versus burden becomes critical. Benefit refers to symptom improvement, mobility, or life expectancy. Burden refers to surgical stress, complications, recovery time, and the risk of losing independence. Margaret's daughter told me something that stayed with me for years. She said, "We thought we were fixing her back pain. We never realized we were risking her independence." And that statement captures the heart of medical decision-making after 70. The goal isn't simply fixing what appears abnormal on a scan. The goal is protecting function, cognition, and quality of life. Comment the word independence if staying active and mentally sharp matters more to you than simply correcting every medical finding on a test. Because in the final section, I'm going to walk you through the exact questions every older adult should ask before agreeing to surgery. These questions are used in geriatric medicine and surgical decision frameworks around the world, and they can completely change the conversation between patients and doctors when evaluating whether a procedure truly offers more benefit than risk. Before any adult over 70 agrees to surgery, there are several critical questions that experienced geriatric specialists recommend asking, because these questions reveal whether a procedure is truly necessary or whether safer alternatives exist. The first question is simple but powerful. What happens if we do nothing right now? In many cases, especially with conditions that progress slowly, the answer may surprise you. Some spinal conditions, mild carotid artery narrowing, stable coronary artery disease, and certain early cancers can often be monitored safely with careful follow-up. Understanding the natural progression of a condition helps patients weigh whether surgery is urgent or elective. The second question focuses on expected benefit. What specific improvement should I realistically expect after the procedure? For example, in knee replacement surgery, doctors often evaluate whether pain is severe enough to limit walking, climbing stairs, or performing daily activities. If symptoms are moderate and manageable, conservative treatments such as strengthening exercises, physical therapy, and weight management may provide significant relief without surgical stress. The third question addresses recovery. What will rehabilitation involve and how long will it take? Recovery after major procedures often includes weeks or months of physical therapy, medication adjustments, and close medical monitoring. For older adults, the ability to participate actively in rehabilitation strongly influences outcomes. A procedure that technically succeeds in the operating room may still lead to disappointing results if recovery demands exceed the patient's physical capacity. Another essential topic involves cognitive health. Older patients and their families may ask surgeons about the risk of postoperative delirium or cognitive changes, particularly after longer procedures requiring general anesthesia. Preventive strategies sometimes include minimizing sedation, encouraging early mobility, maintaining regular sleep cycles in the hospital, and ensuring adequate hydration and nutrition during recovery. These steps can reduce complications related to confusion or temporary cognitive decline. Patients may also wish to discuss non-surgical options in greater detail before making a decision. In spinal conditions, targeted exercise programs designed to strengthen core muscles can stabilize the back and reduce pain. For vascular disease affecting arteries in the neck or heart, medications to control cholesterol, blood pressure, and blood clotting often reduce stroke or heart attack risk. Lifestyle interventions such as balanced nutrition, regular physical activity, and smoking cessation play a powerful role in managing many chronic conditions. For men experiencing symptoms of prostate enlargement, medications that relax the prostate and bladder muscles can improve urinary flow and reduce nighttime awakenings. These treatments may delay or eliminate the need for surgery in some individuals. Another valuable approach in complex medical decisions is obtaining a second opinion. Consulting another specialist can provide additional perspective on treatment options and clarify whether surgery is strongly recommended or simply one of several possible strategies. In many healthcare systems, shared decision-making models encourage patients to participate actively in these discussions. Doctors provide medical expertise, while patients express their priorities, values, and goals for quality of life. Some individuals prioritize maintaining independence and mobility for as long as possible, while others focus on aggressive treatment of disease. There is rarely a single correct answer for every patient, and thoughtful conversations can help align medical recommendations with personal goals. Families often play an important role in these discussions, especially when recovery from surgery may require temporary assistance at home. Planning ahead for transportation, physical therapy visits, medication management, and daily tasks can make recovery smoother and safer. Ultimately, modern medicine offers remarkable surgical technologies that can restore function and extend life in many situations. However, careful evaluation of risks, benefits, and alternatives becomes increasingly important with age. For adults over 70, thoughtful medical decision-making allows individuals and their healthcare teams to select treatments that support not only longevity, but also independence, comfort, and overall well-being.